Hi, my name is Carolyn Hughes. I am a fourth-year PhD student at UCSF studying perinatal epidemiology. And in my research and my training, I take a mixed methods approach, meaning that I draw from qualitative, quantitative, and policy analytic methods to understand the clinical and experiential factors that affect maternal and newborn outcomes. And part of why I look at experience of care is because it is so inextricably linked to clinical outcomes, mental health, and future care seeking. And so I'm excited to present to you today my research on respectful maternity care reporting among health workers in Malawi. This is a study that we recently presented at a major international health conference. And part of why we're looking at health workers is that it makes sense that they're critical to patient outcomes and experiences. But as you can see here, the health workers themselves operate in an extremely complicated setting and environment as they try to deliver care. And so our research questions and objectives really center around these health workers, around what their perceptions of care and experiences are like. And they're a fairly understudied population, especially in lower resource settings, which is part of why we conducted our study. Again, our study takes place in Malawi, and our study draws from surveys of nearly 300 health workers in 25 health facilities in the country. And our main outcome that we look at, that we use to study experience of care, is the person-centered maternity care scale that encompasses several domains that, when you put them together, really embody what high-quality person-centered care looks like. And so when we looked at the provider reporting of care that they provide, we found really fairly low scores in terms of communication and autonomy reported by the health workers, but really low levels of overt abuse and somewhat middling scores when it comes to the level of supportive and responsive care that they provide. But when we looked at our predictive models that we developed to try to see what factors about the providers or the facility can tell us about higher or lower levels of reporting of PCMC, we found that modifiable provider factors were associated with PCMC. For example, the amount of time that the providers spend in training or the level of clinical confidence that they had in the care they provided were both really strongly predictive of PCMC scores. And when we look at the health facility, the facility culture was very strongly associated with PCMC, with high levels of emotional exhaustion and burnout being related with lower quality of care, and a positive and supportive relationship with their manager being strongly associated with higher levels of PCMC. And so in conclusion, we must consider health worker experiences and needs as we work to improve quality and experiences of care for patients. Our analyses focus on factors that haven't really been widely explored before, and we found unique insights into modifiable factors that we can work on to improve quality. We feel that interventions must be multifaceted and address psychosocial stress and facility culture in addition to clinical skills. But we do caution that future studies should look at potential reporting or sampling bias whenever we look at health workers. Before I end, I would really like to thank the ARCS Foundation for your generous support that really helps make this all possible for students like me. I'd like to thank my mentors who have been so wonderful in giving of their time and expertise, the health workers and women in our study in Malawi, and also our colleagues at the University of Malawi and USAID. Thank you so much.